Good afternoon, everyone, and welcome to today's webinar, Don't Fear the CVO. Thank you for joining us. I am Lisa Allen, President of the Michigan Association of Medical Staff Services, and I will be the moderator for today's program. Today's webinar is being hosted by the Michigan Association of Medical Staff Services and sponsored by the Hardenbergh Group. Before we begin today's program, I'd like to share a few housekeeping details. All attendees' microphones have been muted for this presentation. To ask the presenter a question, click on the Q&A icon located on the navigation bar at the bottom of your screen and type in your question. You will also see a chat icon, which can be used to submit comments during the presentation. As time permits at the end of the program, I will read the submitted question and ask our presenters to respond. This program is being recorded. If you know someone who has not been able to attend today's session, it will be available on the Hardenbergh Group's website approximately 48 hours after this program has concluded. Your CE certificate will be emailed to you within 48 hours directly from Hardenbergh in your "Thank you for attending" follow-up email. A link to a short survey will also be included. We hope that you take a few minutes to share your feedback. Now it is my pleasure to introduce today's presenters, Cindy Agostino and Holly Virden. Cindy Agostino has over 18 years of credentialing experience in the areas of credentialing, privileging, delegation, provider enrollment, accreditation, and regulatory compliance, as well as CVO development and certification. Cindy is a high-performing, strategic thinking professional with extensive experience in healthcare, operational, and managed care environments. Cindy also possesses a broad background in CVO development and established multiple from the ground up, achieving NCQA certification accreditation. Cindy is dedicated to meeting the needs of the healthcare industry by working with high-profile clients and systems to better their processes and efficiencies. Holly Virden is a strong partnership strategist with over 26 years of healthcare experience covering many facets of the industry, from finance, legal, and compliance to her current role as the director of the Steward Healthcare Credentialing CVO. Steward is the largest private tax-paying hospital operator in the country, serving over 800 communities with over 12 million patient encounters per year. Our family of hospitals have received the nation's top awards for quality and safety. The Steward CVO currently maintains compliance operations in 35 community hospitals across 9 states and is NCQA certified. And now I'd like to turn it over to Cindy and Holly.
Hey everybody, thanks for joining us today. Cindy and I are actually excited to get started. See if we can get our slide deck to share here. We will get started. Can someone give me confirmation you can see our screen?
Yes.
Awesome.
Looks great.
You know who we are. But when there's credentialing files and a lot of administrative responsibilities to manage, the workload can become overwhelming for a facility that's trying to manage all of the components that mark success. So, more than ever, decision makers are choosing to outsource the administrative task to a centralized credentialing verification organization. So when in-house resources are stretched thin or duplications by multiple locations in one system become cost prohibitive, this really can be a great option and a great solution if you guys do it correctly. So we also understand that releasing your credentialing process to a CVO can feel like a loss of control, and it can make decision makers feel uncomfortable. So there's several reasons why a CVO is a good idea for your organization, And there's a lot of potential pitfalls, but we can help you avoid those as well. So Cindy and I like to explore some of these items with you inside of this presentation. Everybody good to go? Rock and roll. So whether you're thinking about implementing a CVO or if you're working with an established one, at the conclusion of this presentation, we're hoping that all the participants will be able to define the different CVO structures and strategies. There's a million different ways to set this up. We want you to be able to recognize those benefits of working with a CVO, and then identify those key skills and strategies that's going to effectively integrate into a CVO structure compliantly. So with that, we're off to the races.
So, so the slide that we have up now, it's, really with budgets being stretched thin and healthcare facilities are under increasing pressure to reduce the operating costs and streamline the processes. Using a technology-enabled CVO for credentialing has been shown to save between 20, almost up to 80% over in-house credentialing. Centralized credentialing can, in fact, lower overhead.
Right, and many of the problems with today's credentialing process stems from the fact that neither the people nor the systems are solely focused on or optimized typically for credentialing. So credentialing staff or medical staff are typically forced to juggle your credentialing duties with a ton of other tasks. And in a similar manner, hospitals often don't have the right tools or software that's designed specifically for credentialing. So I can't tell you how often we hear, oh, we have that on a spreadsheet. Makes us cringe, but employees are relying on these offline processes to make do, get their jobs done with these makeshift programs. So spreadsheets and checklists, I can't even talk today, sorry. Spreadsheets and checklists are important and imperative, but this is an inefficient process, which is going to naturally lead to errors. And so for those people that do have those systems in place, they're not even fully implemented most of the time. So that, or the team isn't adequately trained.
Right, yeah, Holly, and then, by moving from a paper system to a cloud-based system, that solution, the costs of credentialing can be lowered without negatively affecting the health and safety of our patients.
Right, so that's the biggest win. Centralized credentialing can really lower overhead overall. So the big question is, for most people on the call, will a CVO affect my job security? So centralized organizations can be extremely efficient, standardizing file processing through these trained specialists, but that allows the local medical staff to shift and focus on those tasks such as managing the privileges or business decisions, provider relations, OPs and FIPPs, committees, and all those administrative duties that really kind of get neglected when they're trying to keep up with the constant influx of applications. So this means that the company is going to rely on a team environment at different levels inside of the business. But the individuals at each level in the organization can retain autonomy to make those privileging decisions, develop and administer those medical staff duties a little more effectively and efficiently.
Yeah, and so in-house credentialing staff are often forced to use like a hodgepodge of tools, consisting of a mix of spreadsheets, personal checklists, paper files, making it difficult to communicate the status to other groups within the organization on a timely basis. This is especially challenging in a large hospital setting with credentialing duties spread across multiple departments.
Right, and it's often not uncommon for different versions of the same document to exist. So the staff's constantly needing to compare the dates and make sure they've got the latest version. On the other hand, CVOs rely on this cloud-based real-time credentialing software that's going to automatically check for those errors, and it's going to ensure that the quality is improved, while it's going to help, again, lower that overhead.
Yeah, and most CVOs are designed to alleviate the administrative burden of processing applications for the medical staff office, and they would reduce provider abrasion to spare the administrative duress of processing multiple applications for the same provider who's being privileged at, a couple of hospitals within your organization.
Right. So working with a CVO does redefine the work of an MSP, but that's related to the file credentialing, but that can actually free that medical staff professional up to focus on other areas that they most likely didn't have the bandwidth to tackle previously. However, implementation of a CVO can result in a reduction of medical staff personnel. We want to be honest and open about that. However, in our case, We did lower our on-site staff at each facility. However, several of these people that we've repositioned, we've offered them positions within the CVO, and from their lips, they have said this has reinvigorated and reinvented their career path, and they're happy as clams working in the CVO now. So sometimes it can be a FTE reduction. However, there is a way to repurpose and restructure to make sure that's a win. So there's still more advantages to why a CVO makes sense. So we can continue to kind of jump into more of those whys now that we've covered the big white whale. Will it affect my job security? Yes or no?
The elephant in the room. Yeah. So why a CVO? There are fewer human errors. There is a cost savings. There's less paper, greater security, improved labor efficiencies, quicker turnaround times, shorter time to revenue, which is always what the hospitals are looking for. But many of the concerns with today's credentialing process stem from the fact that neither the people nor the systems are solely focused on or optimized for credentialing.
Right. And by moving from a paper system to a cloud-based computing solution, the cost of the credentialing files can be lower without negatively affecting patient safety. So cloud-based credentialing means there's no need to secure faxes and other documents in filing cabinets. And I don't know, you can't see my hands, but paper cuts be gone. I have more scars from paper cuts than I care to admit from all those file days. So that quicker turnaround time will equal that shorter time to revenue, as Cindy mentioned. But the labor inefficiencies are improved because those redundant tasks are eliminated. So administrators are also better able to predict the future cost. And then you'll see the last bullet item is budget appropriately. So they can actually plan ahead and structure finances for the coming need, and it should be a lower cost. So in light of some of these benefits, let's talk through some of the different CVO scenarios so that you have the insights for each structure. Again, there's several different ways that we can actually structure this. So we wanted to make sure that we gave you a couple of different options that are the most popular. So it's kind of a question as old as time, or maybe just the 21st century when all this technologies come in, but really, should we centralize, should we decentralize, or should we distribute our credentialing processes? So there's a lot of variances in how the medical staff offices are set up, how your facilities are set up. You guys might all be independently licensed, which is kind of our case, or you might operate under one license, which means you can roll things a little differently. However, your organization is structured is going to be how your processes are defined and developed. So to quote our colleague Renee Dengler, if you've seen one CVO, you've seen one CVO. There's just so many different options when structuring a CVO for your operations. You really just need to break down the different kind of variables of what is going to work best for you and your facility. So we're going to look first at the centralized model.
Right. So in a centralized credentialing world, there's one department which controls all of the credentialing activities and initiatives and manages a unified process for the entire system.
Yeah, there's a lot of benefits to the centralized credentialing team. But by far, the main advantage I've found is that it's the economy of scale that it provides.
Yeah, with the skills, resources, systems, vendor management, and data all housed in one place, budgets are easily managed and controlled. It's a cost-effective and streamlined, allowing systems and technology integration to be simplified to cut costs. So it can also provide a better understanding of the customer journey. On the other hand, there are a few disadvantages that should be considered. I'm sure all of you were thinking of them. Poorly implemented centralization can stifle the entire initiative. It can constrain the ability to tailor products to local services, which in practice can burden business divisions, more so with high cost and disconnected service expectations. So since everything goes through a centralized team, it also is potentially can become a bottleneck if volumes run high, or if there's a break in the process flow. Plus, the inability to customize on a local level is a main roadblock for centralization. Different business units or regions need to be able to tailor their processes and goals from market conditions and adapt to the local lingo, so to speak. So in this age of personalization, centralized credentialing, it could conceivably miss the mark of that communication is lacking.
Right. So in today's world, let's just throw out the word telehealth is our case in point. So there's definitely a need to standardize processing those files just to help us maximize those efforts. So for large organizations, centralization really does reduce provider abrasion. It stops requests to complete multiple applications. It prevents applicants from providing documentation multiple times. How many times have you guys heard, I've already given that to somebody, and then paying multiple fees, and then applications are being processed duplicatively across all local areas. So that centralization really could help line up everything. And this particular model will mitigate that risk. It'll lower expense and make your turnaround times much faster. So Cindy, let's go ahead and talk about the decentralized model.
Sure. So we're on model number 2. So on the other end of the spectrum is the decentralized credentialing. This results in multiple hospitals that are all separately responsible for their own credentialing activities. We normally see this type of an environment in larger hospital organizations that have multiple medical staff offices with varying processes and solutions. This can really double the efforts, the expense, and can introduce risk due to inconsistent processes.
Right, and these organizations usually have a diverse range of needs. So, it could be supporting a managed care organization, a hospital, there's all these lines of service now in the 21st century. So decentralization will allow credentialing processes to commence without the interference of the parent company. So that means the local medical staff professionals are able to specialize in their target area, resulting in those more focused processes. And that does improve provider communications.
True, but in a decentralized model, local knowledge and responsiveness to providers and market is a key benefit. They know their providers, they know the process. So one of the most important roles of an on-site credentialing team is their working knowledge of the local regulations, market conditions, and the provider idiosyncrasies that we run across on a daily basis. So, in contrast to centralized credentialing, is often removed from the frontline reality and can make decisions in a vacuum that don't always represent the best for all of the local facilities.
Right. However, decentralization does come with its own challenges. So with all of your decentralized teams doing their own thing, you can end up with multiple systems, multiple strategies, data inconsistencies, which all threaten data integrity. It's going to inflate your cost. It's going to overcomplicate those workflows. Your reporting is going to go out the window. And then it can also lead to like duplication of work or performance tracking. And then that larger lack of framework that isn't scalable if you start to add hospitals. So the next option is what we've actually implemented here at Steward. And it's kind of a combination of both of these, the distributed or the decentralized and the centralized, in which we are calling the distributed model.
Yes. So this third model is, like Holly said, is the one that's in place at Steward. Distributed credentialing teams combine the best elements of the centralized and decentralized models that we just talked about. This option is gaining significant traction with larger healthcare systems as it offers a number of unique advantages. The centralized verification office streamlines the credentialing initiatives, provides one point of entry, performs primary source, and manages expirables, which all benefit the local medical staffs. So the key really is there's one point of entry for the provider, and then it's distributed to all of the medical staff offices where he's applying for privileges. So no more redundancies and just one application. And the CVO processes it with, the primary source and then shares them downstream.
Right. So this model really lets us cherry pick the best of both worlds. So it allows us the corporate core and local level to work together to leverage those central resources, as well as capitalize on that local knowledge and expertise. So in a distributed credentialing structure, the centralized team actually maintains control of the intake and the processing, which is standardized, consistent, and efficient, which is going to minimize provider abrasion with that one point of entry, like Cindy said. And then it's going to help remove that administrative burden on the local medical staff office. So by the CVO completing the application and the verification process, both timely, this allows the receiving MSO to focus on privileging that physician staff needs and those items, again, that we've talked about earlier about managing LPs and FIPPs and those practitioner relationships, which really are that local advantage that we want to make sure we maintain. So another benefit to how we established our distributed credentialing team is that the same platform is used. So that ensures that all of our data is stored centrally and it's consistent and it's accessible to all of its parties. So we have a data standardization and we want everybody to use the fields the same way for the same reasons, so we can have reporting and be able to use that on both a national and a local level. So it also allows the team to monitor performance and centralize, again, that reporting piece. Our role-based security allows medical staff offices to consume the electronic data in real time, as well as systematically retrieve the files completed by the CVO. So we're completely paperless, moving files back and forth with each of our medical staff offices. So the nice thing about this also is that we're NCQA certified. So we have a little lockdown zone where they can't make modifications to information that we've verified. So we have our little perfect piece. This is what we process and how we have it, but they have all of the data right in front of them without having to actually go chase that down.
Right. So from a CVO perspective, use of an external CVO, they'll send you, or you can download a PDF of the completed file. For example, Steward requires an application process, but be aware, you still may have to manually rekey some data into your system for your committee approvals, tracking expirables, and other information elements that you're responsible for.
Right. So now that we've covered a few of the more common structures, it's going to come down to your understanding of the standards that you operate under as you make decisions to establish or engage with a CVO. So there's a ton of different standards.
Yeah,
these are just some of the more popular.
Yeah, these are the more popular ones, and I don't think you all need me to read these to you because you probably dream about them at night. But yeah, so understanding your credentialing standards is key. A CVO has to keep abreast of all regulatory and accrediting body standards. Not that the MSOs don't, but the CVO, when they have multiple external clients, have to be aware of them from state to state also. So in the case of Steward, they're also managing their CVO to multiple regulatory standards, CMS, DNV, Joint Commission, and NCQA. So as you can see, there are many standards which will determine the process you choose to implement. It would be up to you to research and understand what you need in order to meet compliance. So to be ready to ask the CVO those questions that are pertinent to you and your regulatory standards.
Right, which is going to lead us to the service level agreement.
Yes, and a service level agreement is a commitment, usually in measurable terms, between a service provider and a client. You'll find common areas represented in this slide, and truth be told, it's really important to set, when you're going through that contracting with the CVO, set those service level agreements because they need to be held accountable to deliver your products timely. And you want to be able to hold them accountable, and if necessary, if there's a monetary stake, then we get some monies back for them not performing to their promises.
Right. And so to ensure like our NCQA certified CVO meets muster, our service level expectations all tie back to how we wrote our standards in our NCQA survey. So basically for our CVO processing timeline, our initial file, our target is to have it within 45 days. 60 days is our hard line. So our current performance is 97% of those initial and reappointment files have a release turnaround time of less than 40 days. So we're meeting our metric, right? But we have our metric set where it's realistic, but we also want to always beat that. And then we track client complaints and we make sure we respond to those within 24 hours. We have annual quality improvement plans that we work through. We monitor those accuracy and completeness of data entered. We have quite a few different things that we put in place so that we can make sure we meet those metrics. And as the saying goes, you're only correcting what you're checking. So that's what we make sure that we check a wide berth so we have a good service to our clients. So we essentially set up our goals based on our performance needs, which is what our CVO work ties back to and how it pushes downstream. And those are all things that you're going to want to consider as you embark on working with a CVO as well. Or if you already have one in place, you might want to make sure that you get some things in place that will help you.
So thinking of implementing a CVO, let me kind of give you a quick little backstory. So I was actually in Holly's position previously, so I was hired by Stewart to create a CVO. They had 9 hospitals within the state of Massachusetts, and demographically they were commutable from hospital to hospital, but every provider had to be, and I alluded to this earlier, every provider had to apply and be privileged independently at each hospital. So there were multiple applications, multiple fees. There was, a data integrity issue because some hospitals were asking for some information and others. So, there was a lot of provider invasion, and that really is what we'd like to get away from. So there's about 5 things that we have here that we would suggest you take into consideration if you're going to implement a CVO. So one of the key strategies for success is engage key stakeholders, especially those closest to the problem. So for example, you need your CMOs to agree that this is going to be the best process going forward. So they're communicating that. And then everyone, kind of just once they hear it from leadership, they think, okay, well, it is going to go into production and it's a good idea. So it is fundamental to get leadership buy-in from the get-go. You don't have to get leadership's total commitment. You do have to get, talk about an oxymoron there. You do have to obtain leadership's total commitment, or you won't get very far without it, because people will start asking, well, did so-and-so CMO agree to this, or, scenarios like that. So engaging these key stakeholders, such as the CMOs at each facility, and maintaining that ongoing conversation is imperative for the success of the CVO to roll out.
Right. So the second part we have down is communicate. Communication is going to come up in our presentation multiple times because it's so imperative. It's really going to be your responsibility to sell that CVO concept if you don't already have it in place. But that consistent communication is what's going to be essential to whether or not that moves forward. So you have to help those adopters really understand that a physician's not going to have to complete 40 applications. They can complete one single application, even if they're requesting privileges at multiple places. Or maybe your scenario is a little different, but the single point of entry means fewer interactions with only one point of contact. So you're going to want to communicate any of those synergies that you're going to gain by working with a CVO early and often. So you're going to want to make sure you reiterate any chance you get.
Yes, and one of the keys is also effective project management. Ultimately, we would recommend that you have a PM to lead the team to accomplish the tasks on a determined timeline. However, regardless if you have a dedicated PM or not, keeping the project on the right track and on time is crucial to the success of the implementation. The leaders must ensure that the mission is accomplished without undue delay.
Right. The next thing we're going to ask you to do is to identify and engage best practice experts to facilitate decision making. You don't have to have all the answers, but you have to be able to find out where they are. So key stakeholders need to have the knowledge necessary to push the project to fruition. If you have a hole, if you don't have that in your talent pool, then you're going to have to consider outsourcing either an expert or so you can get to best practices, or you're going to have to find someone to pull onto your team that can help kind of fill that gap for you. That's going to be something that you're going to want to model for the future, so that you can make sure that you have all of the data entry points that you need as far as knowledge in the room, so you can move forward quickly and effectively.
And I think out of all of the things listed, this is one of the key elements, which is data standardization for every field is necessary. Active involvement by all the stakeholders in determining the future model is crucial. Without standardization, it is virtually impossible to pull all reliable reports, or, be able to track productivity and produce reports on, metrics and, revenue turnaround time. So, at Stewart, there was a credentialing data manager, and that position, it was Holly, actually. In that position, she was responsible for managing these relationships and working to determine the standardization fields to ensure the data integrity through the entire system. And it is a
Right.
lot of work. The data standardization is a lot of work, but it certainly makes the outcome even better because you do have a central source and a true data source. And you maintain that data integrity throughout all of your hospitals.
Right. I like to view that as the bumpers on the bowling alley lane. You just want to keep the ball so it keeps going straight. So maybe you've already considered a CVO and you're at the next step. Maybe your CVO is operational. Now what are you going to do? So Teddy Roosevelt said, single ingredient in the formula of success is knowing how to get along with people. So we're going to talk a little bit about how to manage those key stakeholder contributions.
Yes. So once the decision is made to implement an internal or external CVO, developing and maintaining those positive relationships, again, through ongoing communication and transparency between the medical staff office and the CVO is one of the main factors relating to the success of the plan.
Yeah, and we understand it can feel a lot like you're herding cats and corralling chickens, thus the graphic. But especially when you first start to build these group relationships, know that people see the success of working together as a team, that group morale and that productivity really is going to soar. So here's some tips on how to manage these relationships.
Yes. So keys to developing and maintaining positive relationships. Learn to give and take feedback. The ride is bumpy no matter what, right? So, but you have to choose to speak up, to represent your interests, and be willing to incorporate outside opinions to determine the best practice for the organization.
Right. That goes hand in hand with accepting differences. You can solve issues before they present themselves by hearing what that devil's advocate has to say. And probably everybody in this presentation has just pictured the person that plays that role in your organization that drives you crazy. But be willing to listen to what they say, because sometimes they have great nuggets of truth. They're going to save you from a bad problem down the road.
Yes. And another thing, these are kind of lessons learned through life too. It's no different, in the work environment, but listen effectively. Most people don't listen with the intent of understanding. They listen with the intent of asking you the next question. So in doing so, basically what you're doing is you're ignoring the person completely. So think before you speak. Give people your time as much as possible. People will respect you if you make accommodations for them in your busy schedule.
Yeah. So I was a broadcast communications major, so I apologize. We're talking about communication every time I open my mouth, but you're going to want to engage all of your communication skills. So you need to have confidence. You need to speak from knowledge or your experience. You're going to want to be friendly. You want to be concise. You want to be respectful. There's a whole list, but you really need to understand that communication is going to be key for everything that you move forward working with a CVO. If there's something broken, you need to communicate so they can fix it. If something's great, you need to communicate so they know that works well. The next thing on the list is learn to trust more. So probably the number one thing that I experience on a daily basis as we bring on new facilities is that preconceived notions. You have to really let go of your personal ideologies and let the process work out. If you have a concern, raise it. Let someone address it. If they can't address it, then work on a plan to formulate to make sure it is addressed. So there's no right or wrong way when you're going through this, but you need to be able to trust that this is going to work out okay. No one's going to lose an eye, and you will be okay at the end of the day.
Yeah, so the last one we have listed here is practice mutual respect and consider all contributions just as you want you to have yours heard, right? So treat others like you would want to be treated. And by developing those good working relationships, you'll grow in confidence and understanding and effectiveness, tying to your personal development and your influence. So it's a lesson learned for you also.
Exactly. So now it's crucial to adhere to expectations, but you're going to want to do this together. So it's important when you first set out on a mission like this to determine who does what and why they do it.
Yeah, establishing expectations within the first group is a must, and make them clear to yourself, for yourself, actually.
Yeah, it's pretty difficult to build mutually clear expectations with others if you can't verbalize or even execute on paper what it is you're trying to articulate. So if you can't clearly do that, you aren't ready for the conversation. Take it back and do your research, have it where you can kind of deliver it in this bite-sized nugget for understanding. And for the record, I'll know it when I see it is not a clear expectation.
Yeah, you need to know where you need expectations. So think about where gaps are. Are they in the work itself? You know, is it the way that we communicate? Is it our timing? You know, what are the organizational cultural expectations that are being imposed? So consider, you know, this is kind of a checklist. Do you have expectations in each of those areas, and are they clear to you?
Yeah. So I'm a big why person. I need to always understand the why before I'll buy in. It's a character flaw, I understand, but so having those clear expectations is good. But I have found that even with my team, giving others the context and the intention, that'll really just make it that much clearer and that much easier for them to consume and to follow. It's really not about justification. It's really about helping people understand the bigger picture. So with the bigger picture, people will understand better and they actually commit a little bit easier.
Yeah, and you know, I mean, really what you should do is meet and discuss, right? So once you have the first 3 steps completed, meet with the others to discuss your expectations. If you don't have, you know, the first 3 steps done, there's a risk, you know, while while you're improved or your expectations may be unclear or incomplete. So it's really important that everybody understands and is in agreement with what the expectations are.
Right. And that's to our last point here. Well, one of the points is make it mutual. So as a key player, you know, you have expectations of others that they need to know and not have to guess, so that they can succeed. And likewise, you're going to have expectations of them that you want them to meet. So the conversation about expectations has to be a true conversation so that both of you understand each other's expectations so that you can move towards that mutual ownership and agreement, and or kind of finalize and finite, I can't meet that expectation. Here's why. How can we satiate that need? Make sure you have those conversations. And then the next part is write them down. You know, we're not talking a legal document here. I've got many people in my life that have actually formalized things on paper napkins over a dinner cocktail. But we know that all things written down do allow for greater clarity. There's an agreement there. Without things being written down or documented, you know, we're relying on our memory. And I'm going to be honest with you, I've made a decision 6 months ago and I can't remember what the decision was. I got to call and ask who was in the call. If you want it clearly defined, mutually understood, and the expectation to be fulfilled, write it down.
Yeah, so don't be afraid to get an agreement and a commitment, right? So once you have them written, it's very easy. It's like a little charter. You know, both parties need to read them and make sure that they understand them and everyone agrees to them. And knowing you both will live with them in the future, right? So, and it was a mutual understanding. So, you know, the lack of clearly understood expectations is a source of strife in working relationships, the cause of most conflicts, and, you know, the beginning of a poor organizational performance. So as the key players, you know, we must strive to build clear expectations throughout the organization. So it really does start with us.
It does. You're the leaders, you're the person called to this, so let's make it happen. Once you've established those expectations, then you can use the CVO to your advantage. So you perform a number of credentialing activities, which are usually handled by the medical staff office. And, you know, a lot of those activities include distributing and receiving applications, doing primary source verifications, evaluating all those findings based on our policies and procedures we have in place, the regulatory standards we operate under. You know, we're going to chase and collect all those letters of reference, and we're going to query in the NPDB, and we're going to verify clinical experience. Those are all super time-consuming tasks.
Yeah, and while a CVO might be more efficient because it devotes its time exclusively to primary source verification, the CVO's true benefit lies in cutting through that red tape to minimize bureaucracy, you know, for physicians who might otherwise be required to complete separate applications for each organization at which they're seeking medical staff membership or clinical privileges. So, you know, for example, a physician who seeks privileges at 10 hospitals may currently be required to complete 10 applications, 1 application for each entity. But if a physician goes through the CVO, he or she only fills out 1 application, saving both the physician and the CVO time. and all involved in processing the application. So it's a save in value, effort, money, and this really does help ensure that high quality patient safety, which I think we can all agree is our primary objective in the jobs that we do.
Right. So by not duplicating that primary source verification effort, and we reduce those subscription fees through combining all those accounts, a CVO can, that's where that savings comes in. That allows us to help standardize that process as well. All of this is going to reduce your administrative burden, which should free you up. Now, standardization is a word we just dropped, and that seems to be a dirty word in the industry. This cartoon pretty much says it all. Why standardization isn't your nemesis is what we want to talk about. But we want you to understand how standards proliferate. And this has happened time and time again. You can all come up with your own circumstances where this has played true. But first, there's these 14 competing standards. What? That's ridiculous. We need to develop one universal standard that covers everyone's use cases. Yeah, everybody gets on board. And then soon, now there's 15 competing standards. And that's pretty common in our industry because there are so many rules and then the exceptions to the rules, right? Fundamentally, process standardization is the establishment of a set of rules that's going to govern how the people in your organization are supposed to complete a given task or sequence of tasks.
Right, and standardization also promotes productivity by eliminating inefficiencies and redundancies. So think about the tasks that you teach each other. You know, how much time had you spent teaching them how to do things that came naturally to you from years and years of practice? How many times have you had to deal with a mistake that someone made because they guessed and they guessed wrong? So standardization really does decrease the ambiguity and guesswork, which is, again, you know, something that you need to focus on, and everyone on, you know, the team needs to follow the same protocols and practices.
Right, and effective standardization of procedures really does mean there's one correct way to do it, any task, right? So it's defined in terms of a clear and a measurable end result. And that can be established by the team. It doesn't have to be just one dictator pushing it downstream, but this is what we've agreed to accomplish together. And one of the most important ways which standardization can really help is to guarantee that quality. And that's minimizing the chances that crucial details are overlooked because work is done in a predefined and a really optimized way.
Yeah, and right there, that minimizes the risk, right? So failure to adhere to regulatory and compliance requirements, you know, exposes the organization to lawsuits, costly fines, penalties, as well as negative publicity and harm to the business reputation. You know, we've seen all of the case studies on the negligent credentialing, et cetera, that, you know, we study for any test that we're going to be taking in the NAMSS world. You know, those are all relevant and came out of, you know, the failure of someone to adhere to those standards. So a CVO really does save an organization significant time and mitigates those risks and costly potentials and liabilities by streamlining the credentialing process. You know, by standardizing the process, your organization depends on enforcing those standards, and then you'll be guaranteeing the quality of the finished result.
Right. So we've talked a lot about working with the CVO and the pros. We don't want to pretend like there's just sunshine and corns out there. There are some challenges of working with the CVO.
As there are, yeah, the benefits of working with the CVO, there's also challenges. You know, one of the biggest challenges is, you know, the preconceived notions made from our own perceptions. And the hardest thing to do, to realize and to swallow, is there may be a better way to do something.
Right. And I don't know if you guys are familiar with the meatloaf story, but a mom was making meatloaf with her teenage daughter, and they've been doing this together for years. And as part of their little tradition, they cut off the ends of the meatloaf before they put it in the oven. So one day the teen girl goes, "Mom, why do we cut off the ends of the meatloaf before we cook it?" And the mom didn't really have a good reason, other than that's how her mom taught her how to do it. So that's how she learned. So then they called up Grandma. "Grandma, why do we cut the ends off of each of the meatloaf ends before we put it in the oven?" And after a brief laugh, Grandma didn't know either. She's like, that's how my mom taught me to do it. So tradition, right? Basically, great-grandmother was still alive. So they all packed up, went to visit her in a nearby nursing home. So the 98-year-old great-grandmother roared with laughter, literally laughing out loud, because she said, "I have no idea why you're cutting the ends off the meatloaf. I cut off both ends because I didn't have a big enough pan. So we've always done it this way. In this case was a simple solution that wasn't related to any of the 3 generations that followed behind great grandma with that practice.
Yeah, so the moral of this story is always question why things are done a certain way and recognize there may be a better way and have those conversations. You know, those discussions will help remove communication barriers. Today, we're all facing, you know, challenges of working remotely and communicating virtually, which is a whole new, you know, realm that we're learning as we go. However, technology provides a mechanism. It ensures us, you know, it is being utilized effectively to convey your perspective, needs, and expectations.
Right. And there can be a feeling that there's going to be a loss of individual control, but people really often underestimate their ability to adapt. So John D. Rockefeller was the one that said, don't be afraid to give up the good to go for the great. So I find that I'm too comfortable with good, and I need to get outside of myself and get help in order to get to that great more often than not. So the smart move is to lean on your colleagues to evaluate and discover the best path forward, not dictate and demand what you want it to be.
But here it's important not to conflate working with a CVO as a lack of innovation, right? So again, it eliminates alternatives which are inefficient and conducive to conflict. By eliminating the inefficiency and the needless conflict in your organization, you know, you can help everyone free themselves from needless waste of time and energy and focus on innovation in your areas in which they really, really matters.
Right.
You do have a voice.
You do have a voice. So we talked about the pros, we talked about the setups, but there are a lot of benefits with engaging a CVO, and that it far outweighs the challenges. So, you know, one of the best things is that you're going to receive that expert credentialing service. Most of my CVO employees are certified credentialing professionals, and they're all equipped with credential-specific tools. So that makes us processing a file more effective, more efficient, because they are focused, laser focused on one task.
Yeah, so generally CVOs build their teams with experts who are committed to providing quality credentialing services to their clients. They perform audits on their credentialing files to ensure quality compliance with accreditation standards. In addition, there might be more knowledgeable, or they should be more knowledgeable about making the right credentialing decisions without compromising a workflow. By outsourcing to a CVO, you'll receive high quality service and advice from professionals who have been trained and certified to manage these credentials. It's what they do day in and day out.
One of the big selling points for your chief medical officers or whoever you need to pitch this to is there's going to be a reduction in cost. So up to 70% reduction, actually, when the credential management work is delegated. So in the case of our Steward CVO, we also achieved a 50% reduction in turnaround times, which also meant a shorter time to revenue. So that actually was a scale balancer for us. An obvious advantage of outsourcing to a CVO is the decrease of in-house responsibilities around that credential management. So we maintain the same amount of transparency, but they don't have to worry about an expirable. We're taking care of that on the front end for them. When a CVO is implemented, there's going to be that higher time value return, since your medical staff professionals can, you know, prioritize quality patient care rather than spending time on those mundane tasks. With those reduction of tasks, that can result in a reduction of hospital FTEs, as we discussed earlier. But like as in our case, I said we've had 4 of those MSPs move over to our CVO operations, and they're happy as clams because the stress level is completely different.
Yeah, so CVOs do have a faster turnaround time. You know, they're highly productive teams with automated processes for managing credentials effectively. The CVOs have developed and optimized their processes over years of providing credentialing service to multiple clients. They stay competitive by continually improving their technologies in the processes to demonstrate their commitment to improving healthcare and maintaining compliancy, but doing it at a faster turnaround time.
Right. And then another benefit is CVOs are a physician has a certain reputation in the medical industry. A facility's bias toward them really might affect the in-house credentialing decisions. The bias might work in favor, or it might work in not to their favor. So regardless of any reputation, the CVOs were completely detached from that facility's preconceived notions. And as a result, that physician and other employees are positively reassured by that fair treatment. They perform, that assessment and the verification of each physician to ensure that the qualified physician can practice, but we're not putting our own slant on it, if that makes sense. So we can also provide that careful and fair monitoring that really is trying to meet those accreditation standards. But this approach really does circumvent applicants from claiming that bias. And then the last benefit is you don't have to do it all. Again, we've talked a lot about how it frees you up to do other tasks, but it really is important to have your hands free to do other things that is equally as important as this. Us mentality. So you're no doubt going to encounter this somewhere along the way. There's just no way around it. So it's important for you to know how to bridge that when it presents itself, because working with other people does not mean that you are working as a team. When you work in a team, you're shifting that focus from you to others, and real teamwork is going to imply collaboration, communication, and then acknowledgement of that common purpose. So a team defined is a group of 2 or more people who interdependently seek to meet a common purpose, often through problem solving, in order to meet their own and their organization's goals. So at a minimum, a team should be a cooperative unit, and at its best, a team should be a collaborative unit.
Yeah, and to be a collaborative unit, you have to engage in collaborative behavior. Think long term. Be open-minded and accept new ideas from others. Don't rush to judgment. Combine strengths and negate the weaknesses to accomplish the goals. You're all in it together. So pull the best from each other and make it the best that it can possibly be.
Right. And then have those active listening sessions, make it safe. Hey, here's my idea. Please, everybody help shoot holes in it so we can get to the best possible solution. And then make sure people can surface any subject. And then you want to turn any disagreements into dialogue and use facts and data to back it up, or tell them, let me get back to you with some data on that once I researched it. You might be right.
Yeah, and then foster mutual respect. Each person has her own strengths and skills. A typical group of medical staff professionals are experts in their field and have insights into their operations. So learn from each other and benefit. The benefit is to everyone. Listen to your counterparts. We do it when we go to the NAMSS conferences, and do this when you're working together and continue to foster that mutual respect.
And trust is a core ingredient, and it's defined as an assured reliance on the character, ability, strength, or truth of someone or something. So trust is hard. Typically, we are natively going to trust people that we've identified with or we've worked with positively in the past. However, trust really is a psychological state that's going to imply those positive expectations regarding those intentions, the attitudes, and their behaviors towards you. So the 4 elements of trust really are consistency, compassion, communication, and competency. So those 4 factors together are what develop trust, which is going to boost productivity and that innovation. And then working together will lead to the plan, the work, and then you can work the plan.
Yep. So plan the work and work the plan. Streamline and standardize the credentialing processes for both initial and reappointment. There are going to always be anomalies, but the foundation should be consistent, and it should align to your facility and your organizational standards. Effectively integrate expirables management, which help ensure ongoing compliance. I think most of us can attest to keeping track of which documents expire and when is a monumental task, especially when multiple providers are involved and you have other things going on in your day. Each expirable has its own renewal period, and its renewal process must be initiated well before the actual expiration date to allow for the processing time. So factor in those potential delays and costly lapses in a decentralized environment. Who owns that?
Right. So efforts can be redundant or competitive. With the CV handling those expirables, that time-consuming task is lifted from MSO shoulders, and again reduces that provider abrasion. One person's reaching out to follow up on that, not 7, 8, 9, 15 locations. Then your system data integrity will become more efficient with that singular intake source, which is processed by the one team that creates a reliable single source of truth for that provider data. And that's going to be across the organization, and that's accessible 24/7, contingent upon, again, that role-based security. So in every organization, it's important that you have that one provider data source of truth that you can rely on and always go back to the well for.
Yeah. So one of the things you can look at is, reduction of provider paperwork and the provider burden. This process improves the provider satisfaction in credentialing, having one process, one application. It leads to the reduction of the application processing time and the timely sharing of the relevant information regarding applicants to facilities, thereby, the risk, it promotes quality and decreases the risk. An effective plan, improve provider coordination, can also reduce healthcare costs. So if the plan doesn't work, change the plan, but never change the goal. Our job as gatekeepers to patient safety really do depend on that.
It really does.
So in summary, we hope our insights to the various models will help you define the best option for your organization and will lead to many of the positive outcomes we've reviewed together while avoiding the common pitfalls.
And we trust you've also come to realize that the preconceived notions really should be left at the door, and your ability to embrace all of the benefits is in this collaboration is really going to be up to you.
Yep. So develop and maintain those positive working relationships, set expectations with one another so you know who does what, where, and when.
And realize standardization is not your nemesis. You want to build those bridges so you can plan the work and work the plan together.
And if you haven't heard this throughout this presentation, communication is the key. Our experience and our insights will hopefully allow you the ability to glean some key strategies on why a CVO is beneficial and how using a CVO to your advantage and practical steps for success in working with a CVO. So in closing, we'd like to thank Hardenbergh Group for the opportunity to share our experience with you. Hardenbergh has been such great partners to us, and we're thankful that we have the opportunity to work with a high quality group.
Yep. And then we're happy to field any questions you may have that perhaps some things we didn't cover or something you need more clarity on, or just general questions overall.
Okay, ladies, we do have a few questions.
Awesome.
Okay, the first one, how does a CVO have a quicker turnaround time? What are they doing different?
Want me to take it, or you got to send it?
Sure, you can. Yeah.
Oh, we just have less distraction. We sit down, we focus on a file, we're able to process the file from start to finish without having to get a call or Dr. So-and-so walking in the office and then trying to get this out the door. It's really just the focused effort is what's really allowed us to kind of dial in our turnaround time a little bit more effectively.
And part of that too is when you're a CVO, you can repurpose verifications. So if a verification doesn't expire for 120 days and you get the provider application in, we've already run that PSV, so we can just apply it to that new file. Whereas from the medical staff perspective, you would have to run it again. So there are some hidden savings in that respect.
Okay. Do your CVOs assist with physician licensing?
Not really.
I guess meaning, we manage the expirables, but we don't obtain the, work to obtain the physician's license to practice.
We do have places we refer them to for assistance, but outside of that, not really.
Okay, thank you. Our hospital system is implementing a CVO, but they are saying they don't have to provide a service agreement to the hospital since the CVO is internal. Do you agree we don't need a service agreement?
I would personally still seek one out, just so you have, again, those written expectations of what it is they're going to be doing and how they're going to be doing it.
Yeah, so the way that I've seen it in multiple environments is it really is you have the CVO agreement with, each one of the hospitals. And then there's usually an exhibit at the end which lists out all of the primary source functions and the application turnaround times and things like that. So those really should be, ticked and tied from a service level perspective, within 30 days, within 60 days. And it should be tied to a specific, and you can get as granular as tying it to specific primary source verifications.
Okay. A CVO only handles the credentialing verifications. What, if any part of the privilege process would be handled by the CVO?
So so at the Steward CVO, it's set up so that they're actually obtaining the delineation of privilege forms. They're obtaining, the collaborative agreements. There's a lot of things that, used to be on the lap of the MSO that now the CVO is getting. It certainly is something that can be done by the CVO. We obtain peer references. So, there's that managed care thought process, and then there's the hospital credentialing, which we know those are two different worlds. But in the Steward CVO, it's a combined effort. So, we're working with the MSOs to take away some of those burdens of gathering that paperwork, but also thinking about, the provider abrasion that we're eliminating by doing it up front. And the providers just working with the CVO to complete, the multiple delineation of privilege forms. I hope that answered your question.
Okay, it looks like this one has a couple of questions within it. More acquisitions of smaller hospitals and/or practices by larger health systems are occurring across the country. Will the CVO model for a hospital system that has multiple locations in neighboring states, Washington, D.C. as neighboring states, Maryland, Virginia, Delaware as neighboring states? So that was, let's see. More acquisitions of smaller hospital by larger systems are occurring across. Will the CVO model for a hospital system that has multiple locations in neighboring states?
So yes, if it's set up correctly, it's scalable. So that's what we were talking about in the different models and determining what your model would look like. So for example, our CVO bridges 9 states and we have 35 hospitals.
It goes on, the complexity lies with different state regulations and different bylaws. How would a CVO model be able to be used for a more streamlined, cost-effective in this situation? Where do you start?
So we have a standardized agreement that we utilize with each of our facilities. And then we also ask them to adopt the Steward standardized bylaws. Cindy, do you want to expand on that at all?
Yeah, no, that's for just the one hospital. So you think, not the one hospital, the one organization. So, there was 32 different hospitals all on different bylaws. So one of the plans, and it was the leadership, the key stakeholders who planned this, is in order to move your medical staff office credentialing and verification tasks to the CVO, you needed to adopt the standardized bylaws for Steward. So that was what would transition, a medical staff office into the CVO. And I mean, it worked very, very well. Some hospitals still are on the verge of not, questioning whether or not they need to adopt the standardized bylaws, but, it really did work pretty seamlessly in that environment.
Do your CVOs have delegated agreement with the payers?
Ours does not. We do have a wing that does, but ours personally does not.
Okay. Second question to that was, how do you deal with each payer having certain specific requirements that are above and beyond NCQA standards?
Yeah, and it is difficult working with them when they set these, they all have different spreadsheets that you have to send them. But from the delegated perspective, it's a different department within Steward. So there's the health plan side, and the CVO is actually just in conversations with that side of the house to now start, becoming one complete unit. So I haven't experienced that yet.
Do your CVOs have, oh, I read that one. Just curious about 90% reduction in cost. Can you drill down a little further?
So I can give you a couple of examples. So for us, ABMS, we all had individual accounts around the country. So you can, they have the base charge, and then they have per user and have how many you're going to be searching for. So let's just say on average, everybody's getting a $5,000 bill annually for ABMS Certifax Access. When we roll them into one, we pay about a $25,000 fee, give or take, right? Based on our needs and based on our use. But now instead of having all these individual bills, it's just one bill. So that decreased our expense significantly. If you take 5,000 times 32 hospitals, and multiply that out, that's a huge reduction right there. So one of the big synergies is really in that account reduction and not having individual per use fees kind of scenario. And that's multiplied by multiple different accounts.
Does the CVO share updated expirables with practitioners' CAQH files?
We do not. You'll update their CAQH files, but our provider enrollment team does.
Has the cost to the local facility been determined if, when an incomplete file is returned from a CVO? For example, if all required peer references are not able to be obtained, and then it is up to the local hospital, is there a cost associated with that?
So typically I do still charge for those because there are hard costs related to credentialing. I'm not talking labor pool. I'm not talking equipment to do the job. I'm talking about getting an AMA, getting an NPDB. So if we've done the work and we can't say get one peer back and we let the hospital chase that, we still do charge because it's really the hard cost that we're trying to recover.
Oh, give me 1 second. There's more questions coming in. I think this was more of a comment. The largest CVO that I am aware of are Hospital Corporation of America. However, they do not consider themselves to be a CVO. They are able to focus on securing PSBs, as you mentioned, and do not have competing time with interruptions. They are able to complete processing much quicker than an MSO without their assistance. Next question. Has the cost to the local facility been determined? Got that twice. How many FTEs are in the CVO, and how many hospitals are they providing services to?
So that's a loaded question. That number is always in flux. We try to maintain an industry standard best practice for X amount of files per provider, or 2 per coordinator. Right now, I think we have 38 employees in the CVO servicing about 32 hospitals.
Okay, I think this is the last question. I'm going between the chat and the question and answer boxes. Does your CVO process reappointments in addition to initial appointments?
Yeah.
We do.
And part of that process is moving all of the providers to the date of birth reappointment cycle.
She faded out there at the end. So part of that process is moving all of our reappointment providers to a reappointment date of birth cycle. So they have one reappointment cycle versus numerous based on how many locations they're at.
Thanks, Hal.
Sorry.
Okay,
No, it's okay.
just a couple more. How many files are assigned to each credentialing MSP?
So on average, I try to shoot for about 45 to 60 on the reappointment side. On the initial side, we try to do 25 to 35. Just depends on if they're teleradiology or not kind of scenario.
And do you have 2 different teams, an initial team, a reappointment team, or are people cross-trained?
We have a little cross training, but most of the time it's just divided out. So we have a reappointment squad and we have an initial squad.
Okay, I think this might be the last question. You stated that you use a PSV if it was run within 120 days. How do you ensure that the PSV will not expire when you return the file to the MSO?
So one of the things that we do is we obtain all of the credentialing MEC and board meetings for each one of those hospitals. So when we're doing that, we will look to see when we completed the file and when their next committee is, to ensure that they're going to get through committee with all valid PSVs.
Okay. Hang on there, still coming in. What happens if you get to the deadline of 45 days and the file isn't complete? Do you hand it off?
So no, technically we have 120 days to complete the application. That's an internal standard that we set just to try to make sure our files are moving in a consistent manner. There are always exceptions to every rule. So if the file goes over 120 days, that's a completely different story. That becomes non-compliant. We have to restart the file scenario. But in a 45-day, no, we notify the client, hey, just a heads up, this file is not going to be out because of X, Y, Z. Give them the why. Make sure they understand that, and then we kind of move forward with getting it out as quickly as we possibly can.
Okay. Someone asked, are you hiring?
I saw that.
Maybe.
Okay.
Yes.
I'm a consultant now, so I don't have any jobs for anybody.
But this is a comment based off of other question. But the hospital does incur costs because their local FTEs are doing the work that wasn't able to be collected by the CVO. The question is whether there is data regarding this cost to the hospital, which is added to the cost charged by the CVO.
Can you repeat that?
But the hospital does incur costs because their local FTEs are doing the work that wasn't able to be collected by the CVO. The question is whether there is data regarding this cost to the hospital, which is added to the cost charged by the CVO.
So the CVO, our CVO does not charge a per provider fee. We charge application fees. So if an application comes through, we collect the application fee and we retain that. So there's no cost per se to the facility. We do have a back billing for reappointments. If we're unable to collect a reappointment fee, we do back bill to the facility. If we don't process the file, I don't have hard costs, I don't collect a fee. To their point, we do have, when we process reappointments, not every provider is responsive. So the response rate last month, for example, was 6.8%. So that means if you have 40 providers that went through the system and we couldn't maybe get 2 providers to respond, those would be pushed down to the medical staff office to complete. They have a 90-day window to complete that application before they expire out. So that's how we handle it. We do not collect a fee. If they want to collect a fee, then the medical staff office can actually pull in the fee for that particular work to cover their FTE expense, if that makes sense.
Okay, does the same person do the initial appointment and reappointment of the practitioner, or do you have an initial and separate team? I think we answered that.
Yeah, we have the separate teams.
How are you going about aligning to birth month? Are you doing it as each provider comes up for reappointment and for all initials going forward?
We're about what, 3 years into this now, Cindy?
Yeah. Yeah, so that was a working together conversation that we had with the hospitals. So in some cases, to move everyone to the same cycle, it required some of the hospitals to reappoint for 1 year and then go to the next year and would be on the reappointment cycle with all the other hospitals. So it takes a lot of work to coordinate that, but generally, between a 3-year cycle, we can get all of the providers on a date of birth.
What is your average turnaround time on initial appointments?
Our initial appointment turnaround time was at 37 days, Cindy, when we just did our recent analysis. 37 days.
Are you 100% remote?
We are 100% remote.
Do all clients have access to view the status of the application?
All clients is a strong word. If they are a coordinator, like a credentialing contact, they do have a portal that they can view the file as it's in process, but not public.
Do you use birth month and year or only birth month?
Birth month. Yeah, it's very challenging if you try and use the year.
What software do you use?
We use Verity's credential stream.
Previously, we were using Cactus.
Great turnaround times. What is the name of your CVO?
It's a Credentialing Verification Office. That's the show.
Okay, I'm not sure some of this. Is the 100% remote new? I was told I would have to travel first before they would consider me for remote projects.
It might just be your organization. I actually was hired on to steward as a fully remote employee a little over 3.5 years ago by Cindy. But I was the first one in our department. Then we had one right after me, and then now we're all remote. So Cindy implemented this about 1.5 years ago, Cindy.
Mhm.
Well before COVID hit.
Before COVID.
Yeah. So it was an incentive for our staff to work smarter versus harder, and to give them an incentive if they met certain metrics, they could work remotely.
Okay. All right, I think that is it for questions. I thank you, Holly. I thank you, Cindy. I do want to remind everyone that your CE certificate will be emailed to you within 48 hours directly from Hardenbergh in your thank you for attending follow-up email. Please take time to do the short survey that is included with it. Our next presentation is scheduled for 6/16/21. That's June 21st at 1 p.m. It is entitled A Tale of Two Peer Reviews. Thank you, everyone.
Thank you, Lisa. Thank you.
Thank you.
Thanks, everybody.